And we will stop here and move on to inflammatory disorders on the next PowerPoint.
Hello, this PowerPoint presentation is over inflammatory bowel disease, and we will also touch on ostomies. Inflammatory bowel disease is a chronic inflammation of the GI tract that's characterized by these periods of remission and exacerbation. And there's kind of two subsets, ulcerative colitis and then Crohn's disease. So ulcerative colitis usually is usually limited to the colon. Crohn's disease can occur anywhere in the GI tract from the mouth to the anus. Usually this begins early adulthood and it tends to have a second peak a little later in life, and it does tend to run in families. There are certain environmental factors that play a role. Diet, smoking, stress, they can always alter the microbial flora. High intakes of like refined sugar, saturated fats, low dietary fiber intake, and a few drug associations with NSAIDs, antibiotics, and oral contraceptives. But that genetic link is pretty strong, and it's also considered like an autoimmune condition. So we see here that we have a picture of Crohn's disease and ulcerative colitis. So you can see the difference. Crohn's disease, there's those kind of skipped lesions, and then ulcerative colitis is more limited to one area of the colon. With Crohn's disease, again, this can occur anywhere from the mouth to the anus, characterized by those skipped lesions, and it does affect all layers of the bowel wall. Some complications that can occur, you can have abscess formation, and even fistulas can develop. With ulcerative colitis, this involves the colon, and it's usually limited to the rectum and lower part of the colon, and it involves the mucosa layer of the bowel, which is like the innermost layer. We do have issues with diarrhea and electrolyte loss because it can't be absorbed adequately through that inflamed tissue, and also substantial protein loss in the stool. Manifestations associated with Crohn's include diarrhea, cramping, weight loss, abdominal pain, sometimes fever, bleeding, fatigue. With ulcerative colitis, bloody diarrhea is fairly common. This can be mild to moderate. Again, these patients might struggle with anemia, anorexia. If the anemia becomes really severe, they can have issues with tachycardia, dehydration, and then also the weight loss, abdominal pain, fever, fatigue that we can also see in Crohn's disease. Other complications for both Crohn's and ulcerative colitis include hemorrhage, strictures, which is kind of like a scar tissue that kind of forms in the intestines and can cause obstruction, perforation, abscesses, fistulas, that's some sort of abnormal passage or tunneling that shouldn't be there, Clostridium difficile infection, and toxic metacolon. So Crohn's disease and ulcerative colitis can be very problematic for patients. Also leads to a higher risk of colorectal cancer, so we just want to consider that. As far as screening, they need to have regular screening and maybe be screened earlier than the normal population. Systemic complications, I'll kind of let you read through these. If they're on steroids, that can also kind of cause complications in itself, increased risk of osteoporosis long term. So good idea to get bone density scans for our older adult patients with inflammatory bowel disease who might have been on chronic steroids. This is diagnosed by starting with history and physical exam, blood studies including CBC, electrolyte panel, albumin to get an idea on their nutritional level, white blood cells, and then stool. It typically has a little bit of blood, pus, mucus, and it might be positive for infection or white blood cells. Imaging studies include barium enema, small bowel series, certain types of ultrasound, CT, MRI, and then also there's colonoscopy and endoscopy. Our interprofessional care involves resting the bowel, controlling inflammation, and preventing or combating infection. We also want to correct any malnutritional states and relieve their symptoms to ultimately improve quality of life. There's a couple different medications and drug classes we can use to help achieve remission. You'll learn more about these in your pharmacology class. They're covered in your textbook, so I'm not going to go into too much detail here. Surgical therapy, this is most beneficial to ulcerative colitis. Why? Because unlike Crohn's, it's usually limited to one section of the colon. So if they remove that diseased part of the colon, it can be curative. Whereas surgical therapy is not as beneficial with Crohn's disease because you have all of those skipped lesions. Here's a picture of a type of surgical intervention with pouch formation. I have some more images. So you don't need to know this in great detail, just kind of be familiar that surgery is an option for patients with ulcerative colitis. With Crohn's disease, again, it's not going to be as beneficial. It can be done to just resect those diseased sections, but then this can result in like repeated surgeries because there's multiple sections of diseased colon, and then you can have issues with short bowel syndrome and dumping syndrome where there's just almost not enough intestines to allow for absorption of nutrients and fluids, and it's kind of like the full food and fluid just runs right through them. So right after they eat, they immediately have to go to the bathroom. You might hear the term dumping syndrome. So beneficial for those patients that struggle with like a short bowel syndrome or dumping syndrome to avoid drinking with meals. Like, don't drink a lot of water with meals, small frequent meals, lay down after a meal to kind of slow that GI motility. Other goals, diet management, really emphasize adequate nutrition to prevent malnutrition and maintain normal fluid and electrolytes. Usually nutritional deficits are due to decreased oral intake or blood loss or malabsorption of nutrients, because again, if you have an inflamed intestines or bowel, it can be difficult to absorb nutrients. So after teaching a patient with IBD about dietary modifications, you determine the teaching was effective when he chooses which menu. I'll give you a second to read through these. And moving on to the answer. If you chose A, you are correct. This is going to provide a well-balanced nutritional meal that will also be fairly easy on their GI tract. In the acute care setting, we want to monitor hemodynamic stability. This includes monitoring vital signs. We also want to control their pain, monitor fluid and electrolytes, nutritional support, monitor eyes and nose, and then also post-op care if they undergo surgery. patient education, it's important that they know about their disease, how to manage it, the importance of rest and diet modifications. If they're taking medications, they need to know why they're on these medications, potential side effects, and all of those good things, and when to seek medical care. That's very important. Our desired outcomes are to have a decrease in the number of diarrhea-like stools, maintain normal body weight, and be pain-free, and also use effective coping mechanisms. So let's talk more about ostomy. An ostomy is a surgical opening on the abdomen that's indicated for fecal elimination. So let's go back to our patient with ulcerative colitis that maybe had that diseased portion of their bowel removed, and so now they need to kind of redirect where feces is eliminated. So that's where an ostomy comes in. If there's not enough bowel to go all the way to the rectum and the anus, they'll have that little outpouching in the abdomen to allow for fecal elimination. If this occurs at the colon, it's referred to as a colostomy, and then ileostomy involves the ileum. Pre-operatively, we want to prepare our patients mentally. This can be very kind of anxious experience for them. They can be nervous because it's altering their body image. So emotional support is very important, providing education. You can also consult the wound ostomy care nurse to help with patient education. And then the surgeon will usually select the stoma site. So it'll be an area on the abdomen that the patient can see easily, but they can still hide easily under their clothes. Post-operatively, we want to monitor the incision, sutures, assess the wound, monitor for fever and white blood cell count, really any signs or symptoms of infection or delayed wound healing. And characteristics of a healthy stoma would be like a normal pink, red, beefy tissue, and maybe just a little bit of blood in that immediate post-operative phase. For our patients and their caregivers, we want them to know how to manage their ostomy, also emphasize diet, balance with adequate fluids, and avoid foods that could maybe cause odorous gas or diarrhea. And then again, emotional support, so important here because this really changes their body image. And then they can slowly resume their ADLs in about 4 to 6 weeks. The pouching system, it involves an adhesive skin barrier and a pouch. We want the patients to empty it when it's about a third of the way full to prevent leaking. A transparent pouch is helpful. It allows them to actually visualize the stoma. When they do change the pouch, we want them to assess the skin. There's certain types of filters that will deodorize any odors, which is helpful. And then also we want our patients to know that bathing, showering, swimming, it's fine. It's not going to harm the stoma. For ileostomies, again, similar management, secure pouching. Very important that these patients are staying well hydrated. They can be very prone to fluid and electrolyte imbalances. And then there is a little bit of an increased risk of obstruction because of that narrowed lumen of intestine, the ileum. So adaptation to an ostomy, really just individualize your responses. Provide that accurate, informative patient education. Give them a positive outlook that this it's curative. And just be aware that emotions can differ patient to patient, but there are support groups available, so that can be a very beneficial resource to refer your patients to.